Well, I got interested in chemical coping after reading a paper by Eduardo Bruera some years ago, and I stole the term from him. Eduardo had noticed that a lot of his patients that had a history of substance abuse, even if they weren't currently using, tended to have this kind of constellation of traits that sort of led to bad coping and a lot of central focus, making the drugs a very central aspect of how they were coping with the emotional and existential and of course physical onslaught of having an advanced disease. And he noticed that they tended to, regardless of whether their distress was existential or physical or what have you, he noticed that they tended to express a lot of this distress in very global, undifferentiated terms, and then and as a result, also tended to ask for and get a lot of centrally acting medications as treatments for that brand of distress. And what he also noticed was they had a tendency to get over-medicated and get delirious and so on and so forth. And so I looked at this notion, and I recognized certain traits: somatization, not differentiating between existential, emotional, vocational, and physical forms of distress. Being overly focused on drug interventions as the only way to help one cope. And of course, not really dealing with some of the important functional aspects of life and taking the benefits of your pain management to another level. And I was really struggling not only with those kinds of folks in my clinical practice, but also in trying to discuss this vast range of patients that exist between frankly addicted people and your adherent folks who use their medicines as more or less as prescribed and are sort of low maintenance kinds of folks in that regard. And I found this term where I worked with a group of psychologists at the time. I was very fortunate. I got together with Ken Kirsch and Dan Bruns and a group of us, and we sat down and we just brainstormed about it, even created the chemical coping inventory, which we've been norming and validating. And at the end of the day, this is a very tough group of patients. If I don't go into all that detail during a lecture, like if it's a lecture on a range of topics and just mentioning this group, people sort of intuit what I mean. They say, oh yeah, I recognize the couch laying, potato chip eating, hydrocodone popping, Jerry Springer watching patients. And everybody will nod their head. They know what I mean. And I don't mean to say that there aren't an awful lot of highly functional people with chronic pain. Of course there are. But there is this group of hard to motivate people, not on a controversial therapy and not making obvious functional gains. And this really is problematic in this era when doctors are constantly fighting with the image of looking like they're drug dealers and so on, that we're really contributing to someone's well-being. And so this is a group that we struggle with. They dabble in misuse, particularly if something bad happens, they lose their job, they're upset, they might overuse their medicines in that context. But they never do something so heinous like crush up their pills and snort them or anything that would cause them to be discharged.